Hi, in this lecture we'll complete our discussion of bradyarrhythmias and then move on to supraventricular tachyarrhythmias, which are among the most common cardiac rhythm disorders encountered in clinical practice. Second degree AV block, type 2, Mobitz 2. Let's begin with Mobitz type 2, second degree AV block. Unlike Mobitz type 1, the PR interval remains constant, but suddenly a P wave fails to conduct to the ventricles, resulting in a dropped QRS complex without prior PR prolongation. Mobitz 2 usually indicates disease below the AV node, most commonly within the bundle of His or bundle branches, and is therefore often associated with a bundle branch block. This rhythm is clinically significant because it carries a high risk of progressing to complete or third degree heart block. For this reason, most patients eventually require permanent pacemaker implantation, even if symptoms are minimal. Third degree AV block or complete heart block. In this condition, one of the atrial impulses reach the ventricles. The atria and ventricles beat independently because the ventricles rely on an escape pacemaker located distal to the block. On ECG, you will notice regular PP intervals, regular RR intervals, wide QRS complexes if the escape rhythm originates from the ventricles. Most importantly, there is no relationship between P waves and QRS complexes. The P waves simply march through independently, a phenomenon known as AV dissociation. Complete heart block is a medical emergency in symptomatic patients. Initial stabilization may require temporary electrical pacing followed by permanent pacemaker implantation. Supraventricular tachyarrhythmias. Now let's move on to supraventricular tachyarrhythmias or SVTs. These are rapid heart rhythms that originate above the ventricles, either in the atria or involving the AV junction. Because ventricular activation usually occurs through the normal His-Purkinje system, the QRS complexes are typically narrow unless there is a pre-existing bundle branch block or aberrant conduction. Patients with SVT commonly present with palpitations, dizziness, dyspnea, chest discomfort, pre-syncope, or syncope. In patients with underlying cardiovascular disease, SVTs may precipitate heart failure, hypotension, myocardial ischemia, or shock. Persistent tachycardia lasting days can even produce tachycardia-induced cardiomyopathy, which is often reversible after treating the arrhythmia. Some AV node dependent tachycardias such as AV nodal reentrant tachycardia, AVNRT, and atrioventricular reentrant tachycardia or AVRT may terminate spontaneously or respond to vagal maneuvers or adenosine. Sinus tachycardia. The first supraventricular tachyarrhythmia is sinus tachycardia, defined as a normal sinus rhythm with a heart rate over 100 beats per minute. The causes are numerous and often represent a normal physiologic response. Common causes include anxiety and exercise, hyperthyroidism and pheochromocytoma, pregnancy, fever, pain, hypotension, hypovolemia, anemia, heart failure, myocardial infarction, pulmonary embolism, and drugs such as cocaine, caffeine, alcohol, beta agonists, and anticholinergic medications. Some patients have inappropriate sinus tachycardia or postural orthostatic tachycardia syndrome known as POTS. Treatment focuses primarily on correcting the underlying cause. If symptoms persist, beta blockers are usually the first choice. Calcium channel blockers may be used if beta blockers are contraindicated. And ivabradine is another option for inappropriate sinus tachycardia. Premature beats. Premature beats, which are early ectopic beats arising above the ventricles. Premature atrial contraction, PACs. PACs originate within the atria. The ectopic P wave has a different morphology from a normal sinus P wave, reflecting its abnormal site of origin. Junctional premature beats. These arise near the AV node. Because atrial activation occurs in the reverse direction, the P wave is often absent, inverted, or appears immediately before or after the QRS complex. This is called a retrograde P wave. Fortunately, premature atrial and junction beats are usually benign and do not require treatment unless they are very frequent or symptomatic. Atrial flutter. Atrial flutter results from a large macro re-entered circuit within the atrium, most commonly in the right atrium, traveling around the tricuspid annulus through the cavo-tricuspid isthmus. The atrial rate is typically 250 to 350 beats per minute, with 300 beats per minute being the classic rate. Fortunately, the AV node blocks many of these impulses, producing conduction ratios such as 2:1, 3:1, or 4:1, or variable AV block. Common causes include hypertension, cardiomyopathy, aging, atrial fibrillation, coronary artery disease, hyperthyroidism, mitral valve disease, cardiac surgery, COPD, pulmonary embolism, pericarditis, and endurance athlete activity. On ECG, atrial flutter produces the classic sawtooth flutter waves, best seen in the inferior leads 2, 3, and AVF. The ventricular response depends on the degree of AV block within 2 to 1 conduction. The ventricular rate is typically around 150 beats per minute. If flutter waves are difficult to identify, carotid sinus massage after excluding carotid breaths, Valsalva maneuver, or adenosine can transiently increase AV block, making the characteristic flutter waves easier to recognize. Let's summarize. To summarize, Mobitz 2 is an infranodal conduction disorder with a high risk of progressing to complete heart block and usually requires a permanent pacemaker. Third degree AV block is complete AV dissociation and typically requires urgent pacing. Supraventricular tachyarrhythmias originate above the ventricle and usually produce narrow QRS tachyarrhythmias. Sinus tachycardia is usually secondary to another conduction, so treatment targets the underlying cause. Premajor atrial and junctional beats are common and generally benign. Atrial flutter is a macro-reentrant atrial arrhythmia characterized by sawtooth flutter waves and commonly presents with 2 to 1 AV conduction, producing a ventricular rate of approximately 150 beats per minute. Now let's continue with multifocal atrial tachycardia, or MAT, followed by atrial fibrillation, the most common sustained cardiac arrhythmia. Multifocal atrial tachycardia is an irregular atrial rhythm caused by 3 or more different atrial foci generating electrical impulses simultaneously because the rhythm is irregular. It may resemble atrial fibrillation, but careful ECG analysis allows us to distinguish between the two. The atrial rate typically ranges from 100 to 200 beats per minute. The ECG demonstrates 3 or more distinct P-wave morphologies, indicating multiple atrial pacemakers. The PR interval varies because impulses originate from different locations within the atria, and occasionally some P waves fail to conduct to the ventricles. MAT is most common seen in patients with chronic obstructive pulmonary disease or COPD or significant hypoxemia. It may also occur in association with hypokalemia, hypomagnesemia, sepsis, theophylline toxicity, and digitalis toxicity. Management focuses on treating the underlying cause. Correcting hypoxia and electrolyte disturbances often resolves the arrhythmia. If rate control is required, calcium channel blockers such as diltiazem or verapamil may be used. Beta blockers should generally be avoided in patients with severe pulmonary disease because they can worsen bronchospasm. Unlike many other tachyarrhythmias, electrical cardioversion, antiarrhythmic drugs, and catheter ablation have no established rule in treating MAT. Atrial fibrillation. We come to atrial fibrillation, or AFib, which is the most common sustained arrhythmia encountered in clinical practice. Risk factors include advanced age, hypertension, heart failure, valvular heart disease, recent cardiac surgery, chronic lung disease, excessive alcohol consumption, and severe symptomatic illness such as sepsis. Patients may present with palpitations, exercise intolerance, fatigue, dyspnea, dizziness, or syncope. In individuals with heart failure, AFib can precipitate or worsen symptoms because the loss of atrial contraction reduces ventricular filling. However, many patients remain completely asymptomatic and AFib is discovered incidentally. Classification of atrial fibrillation. AFib is classified into several categories. Lone atrial fibrillation occurs in individuals younger than 65 years without identifiable structural heart disease. Valvular AFib is associated with conditions such as moderate to severe mitral stenosis, prosthetic heart valves, or previous valve repair, whereas all other cases are considered non-valvular AFib. Paroxysmal AFib terminates spontaneously. Persistent AFib lasts longer than 7 days or requires cardioversion to restore sinus rhythm. Permanent AFib is continuous and persists because cardioversion has failed or is no longer being pursued. Recurrent AFib refers to 2 or more separate episodes. Secondary AFib develops as a consequence of another condition such as acute myocardial infarction, cardiac surgery, pulmonary disease, or hyperthyroidism. Pathology. The initiation of atrial fibrillation most commonly arises from ectopic electrical foci within the pulmonary veins. These rapidly firing impulses, often reaching 350 to 600 beats per minute, trigger multi-micro re-entry circuit throughout the atria. Instead of a coordinated atrial contraction, the atrial fibrillate chaotically. Over time, this rapid activity causes electrical and structural remodeling, making the arrhythmia increasingly difficult to terminate. This concept is summarized by the phrase AFib begets AFib, meaning that the longer atrial fibrillation persists, the harder it becomes to restore normal sinus rhythm. Hemodynamic consequences. The atrioventricular node filters many of these rapid atrial impulses, resulting in an irregular ventricular rhythm, usually with a ventricular rate below 200 beats per minute. Loss of coordinated atrial contraction decreases ventricular filling and may reduce cardiac output, particularly in patients with heart failure or diastolic dysfunction. Blood stasis within the fibrillating atria, especially in the left atrial appendage, promotes thrombose formation, making atrial fibrillation one of the most important risk factors for ischemic stroke and systemic thromboembolism. Stroke risk assessment. To estimate stroke risk in patients with non-valvular AFib, we use the CHATS-2 score. Each of the following contributes 1 point. Congestive heart failure, hypertension, age greater than 75 years, diabetes mellitus. A previous stroke or transient ischemic attack contributes 2 points because it carries highest risk. As the CHATS-2 score increases, the annual risk of a stroke rises substantially. Patients with a score of 2 or higher generally require anticoagulation therapy unless contraindicated. ECG findings. The hallmark ECG features of atrial fibrillations are absence of organized P waves, a chaotic fibrillatory baseline produced by rapid atrial activity between 350 and 600 beats per minute, an irregular ventricular rhythm, which is the classic electrocardiographic signature of atrial fibrillation. These ECG findings, together with the patient's symptoms and the stroke risk assessment, guides diagnosis and management. On the ECG, atrial fibrillation typically presents with an irregular ventricular response, usually between 100 and 180 beats per minute, with the narrow QRS complexes unless there is an associated bundle branch block or aberrant conduction. Occasionally, after a long, short cardiac cycle sequence, transient white QRS complexes may occur, known as the Ashman phenomenon. Because the atria no longer contract effectively, there are no distinct P waves, no A waves in a jugular venous pulse, and no S4 heart sound on oscillation. The primary goals of AFib management are symptom control and prevention of a stroke. Stroke prevention is especially important because untreated atrial fibrillation increases the annual risk of a stroke by approximately 4 to 5%. Every patient should undergo a stroke risk assessment, commonly using the SHATS-2 score, and anticoagulation should be considered regardless of whether a rate control or rhythm control strategy is chosen. For newly diagnosed atrial fibrillation, if the episode is brief, self-limited, and causes minimal symptoms, antiarrhythmic drugs may not be necessary. However, if AFib persists, clinicians should decide between the rate control, rhythm control with cardioversion, or both. Recent evidence suggests that an early rhythm control strategy, especially within the first year after diagnosis, may reduce cardiovascular death and stroke in selected patients. For recurrent or permanent atrial fibrillation, management depends on symptoms severity. Patients with the mild or no symptoms are often managed with the rate control and anticoagulation alone. Patients who remain symptomatic despite adequate rate control may benefit from antiarrhythmic medications or catheter ablation. The choice of antiarrhythmic drugs depends on the presence of a structural heart disease. In patients without significant heart disease, medications such as flecainide or propofenomenon can be used after excluding underlying coronary artery disease. In patients with left ventricular dysfunction or coronary artery disease, amiodarone is generally preferred because of its safety profile in these conditions. If medications fail or are poorly tolerated, radiofrequency catheter ablation is an effective option for symptom control. Treatment of AFib can be divided into 4 major components. First is rate control. The goal is to slow ventricular response and relieve symptoms. First-line medications include beta blockers, diltiazem, or verapamil. In patients with heart failure, dioxin or amiodarone may be more appropriate. Dioxin is particularly useful when beta blockers or calcium channel blockers are ineffective or contraindicated. Second is anticoagulation. Patients with non-valvular atrial fibrillation who have an elevated stroke risk should receive oral anticoagulation. Direct oral anticoagulants, including apixaban, dabigatran, rivaroxaban, and edoxaban. These medications are generally preferred over warfarin because they provide similar or better protection with a lower risk of intracranial bleeding and require no routine INR monitoring. Aspirin has only a very limited role and is reserved for selected low-risk patients with concomitant atrial disease. Third is cardioversion. If atrial fibrillation has been present for less than 48 hours, electrical cardioversion can usually be performed safely, although anticoagulation may still be required in high-risk patients. If AFib has persisted for more than 48 hours, anticoagulation should be given for at least 3 weeks before and 4 weeks after cardioversion, unless a transesophageal echocardiogram excludes atrial thrombose. In patients who are hemodynamically unstable, such as those with hypotension, ongoing ischemia, or acute heart failure, immediate synchronized electrical cardioversion is indicated regardless of AFib duration. Finally, identifying any treatment underlying cause is essential. Common etiologies include hypertension, obesity, obstructive sleep apnea, coronary artery disease, heart failure, valvular heart disease, pericarditis, cardiomyopathy, myocarditis, atrial septal defect, postoperative states, pulmonary embolism, chronic obstructive pulmonary disease, hyperthyroidism, sick sinus syndrome, and excessive alcohol intake, often called holiday heart syndrome. To identify and treat these conditions is very beneficial. AFib may also occur in otherwise healthy individuals, known as lone atrial fibrillation. Studies comparing rate control and rhythm control strategies have shown similar long-term survival in many patients. However, more recent evidence supports early rhythm control in carefully selected patients with newly diagnosed atrial fibrillation. Patients with significant structural heart disease often tolerate AFib poorly because they depend on the atrial contribution to ventricular filling, sometimes referred to as the atrial kick. In these patients, restoring sinus rhythm through pharmacologic or electrical cardioversion should be considered as early as possible. Important points. When managing atrial fibrillation, always think of 4 priorities: control the heart rate, prevent a stroke with anticoagulation, restore sinus rhythm when appropriate, and identify any risk and treat the underlying cause. These principles form the foundation of modern AFib management. SHAD's 65 algorithm for anticoagulation, a simple clinical tool used to determine whether patients with atrial fibrillation require oral anticoagulation to reduce the risk of a stroke. The first question is whether the patient is 65 years of age or older. If the answer is yes, oral anticoagulation is recommended, with direct oral anticoagulants or DOACs preferred over warfarin in most patients. If the patient is younger than 65, then we assess the major stroke risk factor, including previous stroke or transient ischemic attack, hypertension, heart failure, and diabetes mellitus. If any of these condition factors are present, oral anticoagulation is again recommended. If none of these factors are present, we next ask the patient if the patient has coronary artery disease or peripheral artery disease. These patients generally receive antiplatelet therapy rather than anticoagulation. Finally, if none of the above conditions are present, no antithrombotic therapy is required. This algorithm simplifies decision making while ensuring that patients at the highest risk of a stroke receive appropriate protection. Approach to rate and rhythm management of atrial fibrillation. Once the anticoagulation has been addressed, management focuses on either rate control or rhythm control. For paroxysmal atrial fibrillation, treatment depends on how frequently episodes occur. Patients with a low recurrence burden may simply be observed or treated with a pill in the pocket antiarrhythmic approach, where medication is taken only during episodes. Patients with frequent recurrence usually requires continuous antiarrhythmic drug therapy, and some may benefit from catheter ablation, especially if medications are ineffective or poorly tolerated. For persistent atrial fibrillation, the first priority is usually rate control while planning long-term management. Rhythm control is generally preferred in patients who have recently developed atrial fibrillation, typically within 1 year, are highly symptomatic, have significant impairment in quality of life, have difficulty achieving adequate rate control, or have atrial fibrillation contributing to cardiomyopathy. These patients often undergo electrical or pharmacologic cardioversion to restore sinus rhythm. If symptoms improve after restoration of sinus rhythm, rhythm control strategies should continue. However, if symptoms persist despite successful cardioversion, the symptoms may not be caused primarily by atrial fibrillation, and continuing aggressive rhythm control may provide little additional benefit. Patients managed with the rate control strategy should have medications optimized to achieve adequate ventricular rate. If symptoms resolve, long-term rate control is continued. Overall, current management emphasizes individualized treatment, balancing symptoms, relief, quality of life, recurrence risk, and patient preference. Surgical management of atrial fibrillation. For patients who fail medical therapy or require cardiac surgery for another indication, surgical ablation may be considered. The Cox-Maze 2 procedure is the definitive surgical treatment for chronic atrial fibrillation. It creates a series of surgical lesions that interrupts abnormal electrical circuits and has postoperative freedom from atrial fibrillation in approximately 90 to 95% of patients. Less extensive procedures such as the modified MACE combined with pulmonary vein isolation are also available. These procedures are shorter and can often be performed during coronary artery bypass surgery, although long-term success rates are somewhat lower. Catheter-based energy sources include cryoablation and radiofrequency ablation, while newer technologies such as laser, microwave, and ultrasound ablation continue to be investigated. AV nodal reentrant tachycardia, or AVNRT. The final topic is AV nodal reentrant tachycardia, the most common type of paroxysmal supraventricular tachycardia. AVNRT occurs because the AV node contains two conduction pathways. A fast pathway, which conducts rapidly but has a strong refractory period. A slow pathway, which conducts more slower but recovers more quickly. A premature atrial beat can initiate a reentrant circuit that repeatedly activates the atria and ventricles, producing a rapid, regular tachycardia. AVNRT usually occurs in patients without a structural heart disease and often begins suddenly with equally sudden termination. Patients commonly describe palpitations, neck pounding, or sensation of shirt flapping caused by atrial contraction against closed AV valves. Heart rates typically range from 150 to 250 beats per minute. On the ECG, retrograde P wave may be visible immediately after the QRS complex, although they are often hidden within the QRS because atrial and ventricular activation occur almost simultaneously. Treatment of AVNRT. Acute management begins with vagal maneuvers such as Valsalva maneuver or carotid sinus massage, which increase vagal tone and slow AV nodal conduction. If these maneuvers fail, adenosine is the drug of choice because it transiently blocks AV nodal conduction and usually terminates the arrhythmia. If adenosine is contraindicated or ineffective, intravenous beta blockers, diltiazem or dioxin may be used. Patients who are hemodynamically unstable with hypotension, chest pain, heart failure, or altered mental status require immediate synchronized electrical cardioversion. For longer-term treatment, the preferred therapy is radiofrequency catheter ablation, which has a success rate greater than 98% and a complication rate of less than 1%. Patients who are not candidates for ablation may be managed with medications such as beta blockers, diltiazem, digoxin, flecainide, or propofenon. To summarize, atrial fibrillation management involves preventing a stroke with anticoagulation, controlling ventricular rate, or restoring sinus rhythm based on symptoms and patient's characteristics. When medical therapy is insufficient, catheter or surgical ablation provides effective treatment options. In contrast, AVNRT is a reentrant tachycardia centered around the AV node that presents with sudden palpitations and is effectively treated with vagal maneuvers, sorry, adenosine and catheter ablation for definitive cure. Thanks for watching. If you are new to the channel, don't forget to like and subscribe and press the bell icon. See you in the next video.